So we will now open this up to questions from the committee. As I wait for hands to rise, I would like to, or rise up, I would like to ask you, you also and Dr. Brody have communicated a lot with the public and have received lots of feedback from the public. Can you describe the response to the clinical guidance that you've prepared for PFAS testing to clinicians and their response about this guidance? Like, what was their reaction? What was their reflection?
Well, we've only just published these literally a few weeks ago. So the first actual presentation to health professionals will be at this Nantucket event coming up early in September. But for the folks who've seen it so far, some people in the PACEs have seen this and very appreciative of it. Some of those are folks that we had contacted to talk about it and to find out what the PACEs were doing. We've posted this on the Protect Superfund research site. We haven't yet, again, had time because it's so new to get that feedback. But as soon as we did send this around to all the community liaisons and to other, affected groups of PFAS communities, they were very, very happy. And they said, this is the kind of thing we wanted for a long time because we haven't gotten what we needed from the states and from the federal government. And this is it. And they knew that they'd been involved in the planning process. So it was really tailored to them. We will be doing pre and post tests when we do these clinical settings presentations. So that will help us to gather some information about the knowledge that people actually got from these kind of presentations.
Excellent. Thank you. Erin, and then we'll move to Mark.
Thank you, Erin, and thank you both Dr. Brown and Dr. Brody. Those are very helpful talks. I'm curious, in your work with environmental justice communities, often we're hearing about tools and information that community members can share and discuss with their clinicians, but obviously in environmental justice communities, this is not always as easy as it sounds. And I'm wondering, in your work, have you received feedback from those communities or from clinical providers in those communities and participants and community members to help us understand additional barriers or what might be more effective or more appreciated in those communities?
Well, it's interesting you should ask that because when Julie Brody and Roseanne Rudell and I and our colleagues started to work on this, it was way back, 2 decades ago, an outgrowth of the Cape Cod work in the first health exposure study. We expanded that to Northern California and worked in an environmental justice community with a very well-known environmental justice organization, Communities for Better Environment, and worked with a community of Richmond that was bordering the big Chevron refinery there. And we found that these were people who, because there had been a long history of an environmental justice group working with a civic science approach, that there was a very educated population there, and they knew the kinds of questions they wanted to ask. They're the ones who told us how to best present this to the community. They're the ones who told us, here's the way you organize a community meeting, here's the kind of music and food you have, and here's how you greet people, and here's how you do breakout sessions in English and Spanish. And so from that point on, we worked with a number of other environmental justice groups as well, and we found that they are very, very literate in this area, and they're some of the people who know the most about this.
In the Richmond example, the interviews after people got their results would say things like, oh, I knew the refinery was bad, but now I can't just ignore it. And participants did become engaged, and they ultimately won a court suit to limit Chevron expansion. It was quite an amazing example of how personal data could be empowering.
Thank you.
Excellent. Mark, we have 1 minute.
Right. Thanks. So I went through the 2 PFAS REACH documents, and they're incredibly clear, and I think that's going to be helpful for us. But one thing I noticed is that in the document for patients, you mention treatments to reduce PFAS body burden, whereas in the document for doctors, you don't see that list of potential treatments. Is there a reason why it's not in those 2 documents?
I think that we heard a lot of patients were looking, they heard about these treatments and they wondered were they useful because, cholecystyrene had been used by some physicians in the West Virginia area around Parkersburg. But it's not a thing that physicians were usually recommending. We also didn't have a lot of room. We were trying to put this into 2 pages. But we felt that it was mainly the residents who were going to be asking doctors, are there treatments? We've heard about this and should we use it? But thank you for raising that because I think it's worth us, looking back and seeing if we should somehow fit that into the clinical guidance document.
Thanks.
Excellent. Well, this has been an excellent session so far. And now we are going to begin our panel. So we have 3 panelists that have been invited, and I will give a brief intro for each one of them. So we have Mark Nascarelli. He is a quantitative health scientist with broad training in toxicology, exposure science, and epidemiology. He serves as the chief toxicologist and director of the environmental toxicology program at the Massachusetts Department of Public Health, where he's responsible for translating health science research and surveillance into evidence-based guidance to inform regulatory policy and public health practice. He's responsible for directing the quantitative evaluation of the public health impact of exposure to PFAS contamination in environmental media, food, biological specimens, and consumer products for the Commonwealth of Massachusetts. He is PI on multiple health studies and federal grants, including those involving the interpretation and communication of biomonitoring results, translating emerging science to build environmental health capacity in the clinical workforce. He serves as an external expert advisor to the National Biomonitoring Network Steering Committee of the Association of Public Health Laboratories and the Human Health Exposure Analysis Resource of the National Institute of Environmental Health Sciences. So welcome, Mark. I'll now introduce Jessica Nelson. She's program director and epidemiologist with the Minnesota Department of Health. She has served as the PI for various state biomonitoring projects, including a 2014 project that measured PFAS blood levels in an exposed community east of the Twin Cities metro area. This project was a third in a series of longitudinal projects measuring PFAS in longer-term residents of this community. Jessica received her PhD and MPH in environmental health from Boston University School of Public Health, where her research involves epidemiologic analysis of PFAS biomonitoring. Welcome, Jessica. And our third panelist today is Gary Ginsberg. He is director of the Center for Environmental Health at New York State Department of Health. He's also a lecturer at the Yale School of Public Health. Prior to joining Yale, he was toxicologist for the Connecticut Department of Public Health. He serves on a number of national committees, including the US EPA's Science Advisory Board and the National Academies of Biomonitoring Committee. He's also the US EPA's Risk Methods Committee and Inorganic Arsenic Risk Assessment Committee. He has served on the US EPA's Children's Health Protection Advisory Committee and has been an external reviewer on a number of US EPA IRIS documents. Dr. Ginsberg has been called on by other federal agencies to provide reviews, including for OSHA related to silica, also related to cadmium, and with dental amalgams. His risk assessments on fish contaminants, synthetic turf fields, acrylamide, cadmium, all of these have been published. He's also looked at genetic polymorphisms related to these exposures. He's also a member of a standing committee in which this work is stemming from. So we are grateful and honored to have all 3 of you here today. So we have time now to have the panel ask questions of our speakers. So we can, I can begin, one of you can jump in or I can call on one. Mark, would you like to begin?
I'm sorry, Erin, are you asking me, Mark Nascarella, as a panelist, or are you?
Yes.
Well, sure. Well, thanks for the opportunity, first of all, to join you today and contribute to the conversation on this clinical principles for communicating biomonitoring results related to PFAS. I certainly enjoyed both presentations, and as a state environmental health official in Massachusetts, I strongly support, increased attention around exposure assessment and reducing exposures to PFAS. So I would say in that regard, I think all three speakers are certainly aligned. I think in terms of reflecting on what was just said and shared and how that might inform the committee's charge on developing clinical guidance around biomonitoring, I will say I agree with Julia Brody. In my experience, I think the risks of communicating biomonitoring results to the public are overstated. We've shared biomonitoring results in Massachusetts. I personally have shared them with over 500 people and had over 100 individual conversations with people. And I find that they very much value having that individual level report back. Many times it informs public health interventions that individuals can take. I would say, broadly speaking, in terms of the clinical guidance, and I've had a chance to look at it just briefly of what's been shared, I think there's an opportunity to really stress the exposure reduction possibility. And so even absent any clear clinical guidance, I think there's an opportunity to share with the public how one can reduce potential exposures to PFAS in both drinking water and in consumer products. And I think that's an opportunity on report back with the public, and it's also an opportunity on educating the public. I think the other opportunity is broader public health surveillance, even at the state or regional level. We are very limited in the United States on comparison levels that we can use. I mean, broadly speaking, we're all referring to the National Exposure Report. And when looking at those data, there are no data for children that are younger than 12 years old. So we're very limited in the data we have available, and we're also limited in the demographic diversity of those data. So not only is biomonitoring maybe warranted in communities where there's increased concern because elevated levels in their water have been identified, but well-conducted population-based studies that can seek to establish reference levels are needed, because I agree, when there are no health-based levels, I think exposure comparisons become very important, and they're used to understand when something is consistent with everybody else or when something is unusual. And I think right now that's an opportunity. I'd like to just spend a couple minutes sharing my experiences with working with the clinical workforce, at least in Massachusetts. We recently conducted a survey of primary care clinicians in Massachusetts. It's a survey that was clicked on by over 700 clinicians, and we have over approximately 600 full completes of a survey. In my experience, about of the 680 clinicians that completed the survey, only 7% had training in environmental health in the past year. So while we're sharing somewhat technical information with a clinical workforce on PFAS, I think there's an opportunity to do some basic environmental health 101 training with the clinical workforce, so that when we are sharing this information with them, or as Silent Spring has mentioned, when the patients are bringing their report back to the clinician to have a conversation, to make sure that the clinician is well equipped to have that conversation. So I think I'll cede my time to some other public health colleagues.
Excellent. Thank you so much. All right, our next panelist, Jessica, would like to welcome you, and you can give your comments.
Thank you. And thanks from me as well for the chance to participate. These meetings are really excellent and informative. Dr. Brody, I wanted to say thank you for that presentation and for this valuable work. I'm so grateful that the qualitative work especially is happening. It's really helpful to those of us doing biomonitoring in states and other settings. I think we just need to keep doing more of it. We used some earlier information and graphs from Silent Spring and some of the participant report backs we did for PFAS results. This went back to 2010 and 2014. A couple of comments here. I was glad that that upstream question came up in the discussion. I wanted to just comment on that and just how important it is to be clear upfront about what biomonitoring can and can't do. I think the committee's been hearing a lot about this, but so, we, of course, as Dr. Brody said, do this as part of informed consent for participants when we want to be sure people aren't getting something at the end that's different from what they were expecting and are feeling disappointed. So, the blood test is not a clinical test. There's not a clear safe, unsafe level right now, but it can be used to show where your results fit in comparison to others. And as has been mentioned, the other is so much more helpful when it's your own local area or community. So more indication of the need for more local and regional biomonitoring. We too have had almost everybody, if not everybody, say that they would like their results. So I echo what other speakers have said. And one final point here is just on the topic of sharing results over time. We actually found that a little tricky with our longitudinal biomonitoring. I think there are some unique challenges. What does constitute a significant change? Is it going up or is it going down? Is that a lab number? Is that some other measure? Also, if the individual's result did not go down when you maybe thought it would, or when it looks like other individuals' results are going down, how is that received? How can that be messaged? Those are a couple challenges we encountered. And Dr. Brown, thank you as well. I really appreciate the clear, straightforward screening guidelines. That process sounds truly impressive and a model in and of itself. And it does feel like, given all these limitations of biomonitoring right now for interpreting health of an individual, that these screening guidelines become that much more important. And the good news to me seems to be that these are fairly standard screenings that hopefully most people with health insurance are having. I think Dr. Karnyan's point yesterday about uninsured and underinsured people not having equitable access is really important to consider. I wanted to raise a piece here that has been mentioned as well, but is just there's this guidance, but in addition to that, what are the best practices and most effective ways for agencies like ours or other groups to actually get this in the hands of the healthcare providers in a meaningful way? And this is beyond the individual patient to provider level, a little bit more broadly. When we did our biomonitoring in this affected community in the East Metro, we would go to the healthcare providers in the area. We did this through lunch and learn. So we would bring in lunch and have a presentation. And it just felt very hard to really get engagement in people's time. Doctors are so busy. As we've talked about, they're not compensated for this. So I think there is a larger question here about how best to share these really useful guidances and materials a little more broadly with the healthcare provider in sort of a real engaged way, given all the issues with the healthcare system and billing, et cetera. The final point was, Mark mentioned this and it was brought up yesterday, which is just the need to consider the broader public health goals of biomonitoring as it expands and becomes more accessible. So Dean Baker yesterday talked about it as the aggregated data. And we want to help answer a question individuals have. Sounds like the panel's been hearing a lot about that. But if possible, we also want to have findings that can inform, many of the other public health and research questions there are about PFAS. And the example from our state in Minnesota was just how helpful the longitudinal biomonitoring was in answering this key question about whether all these public health interventions that had been made to reduce PFAS in water were effective, and the biomonitoring results really, pretty clearly seem to show that they were. So we designed our projects with that question in mind was one thing. So we tried to do random sampling to get a sample of the community that could be reflective of the larger population. So considerations like this, but I look forward to the discussion. Thank you.
That's excellent. Thank you so much, Jessica. And our final panelist, Gary, Dr. Ginsberg. I'd like to welcome you and have you give your comments.
Am I audible? Can you hear me?
I have a little difficulty hearing you.
Give this a shot. Let me know if it's
In fact, we do not hear you. Okay.
I think you just muted your phone, Gary. Let's see. Because you're the 518 number, right?
Yeah.
That's Gary.
I don't know whether you want to try to call back in.
Yeah.
Because we're just not hearing. Sorry. Oh, there he goes. Let's see if he doesn't come back.
So as we wait, I know the committee's thinking of their questions also for the panel.
Can I quickly just say a couple of things in response to
Absolutely. Take that. Yes, please do.
Thank you so much for mentioning this idea about looking at the effects. And I think you're referring to the Waterfield study, which showed changes in low birth weight as a result of decreased PFAS. I think that generally we should be looking at more of these kind of natural experiments. And I think there will be many of them as we see more regulation coming through at the state level. So that should be a very important research agenda. And also you mentioned the point about getting not just to the individual clinician-patient relationship, but larger. In New Hampshire, the New Hampshire Medical Society invited Andrea Miko, who's been a leader in the citizens movement around PFAS and somebody that you've heard here at the committee. She's somebody who was invited to speak there and was able to then share that information with a very large audience. So I think we want to do more things like that. And maybe Gary can help us get to the people that he surveyed in Massachusetts. And we would be happy to do not just PFAS, but any kind of educational work around other environmental health topics, because I think all of us in this field are always aware of the fact that you mentioned so few people in the medical field get that training, either in med school or afterwards. So anything that we can do, PFAS is going to be a great vehicle because it is impacting so many communities. It can open up a lot of avenues for lots more environmental health education for clinicians.
So Phil, you just mentioned a very important component that I think we've touched on but not gone into, and I'd love to hear this group's thoughts on this. You've mentioned using PFAS biomonitoring as a way for surveillance, to look for changes over time. How often would repeated measures need to occur? What would you recommend, or have you thought that through? If that was the goal, to look at changes over time.
Yeah, this is Gary Ginsberg. Am I audible now? Because I do have a comment.
You are. Yay.
Great. Yeah, I just stuck with one medium instead of two. So
you're very soft. If you could turn the volume or get closer to the microphone.
Gee, okay. I'll do my best. But in New York State, we have about a half-life. So we've gone back to communities after 3 or 4 years, and we've seen, the expected overall community level results dropping, and which showed that the mitigation of the water supply issue had worked. but we're always on the lookout for those whose rate of decline is not what's expected. And in those cases, there may be an occupational exposure or some other PFAS environmental issue to follow up on. So we do think here in New York that the temporal approach is great if you could commit to that in a community and to try to recruit the same individuals to do a second test if they stay local. So I think that is a useful approach that we've seen here in New York. And we also are doing status and trends, more representative, distributed sampling in different regions. And that also helps put some perspective on a sort of New York State biomonitoring levels for emerging contaminants in different regions at different times. So between that and specific source-related communities, we're getting a fairly good picture, although it's still very early on in the overall lay of the land. You know, one aspect, of course, as well is the multi-site study that we're part of with CDC for a couple of our communities. While the information gaps are still there, the uncertainty still exists with what a biomonitoring level means. At least we can talk to people about how the research is ongoing, and hopefully within a reasonable amount of time, we'll have better understanding of what a certain exposure, historic, or, you know, at different age groups, different time points, different lengths of time of exposure, all that is being thought about and analyzed within the multi-site study. And so hopefully we'll have better information for communities as that progresses.
And by the way, I made a mistake before when I said Gary Ginsberg and then Mark Mascarell about the Massachusetts survey.
I could just add on about the longitudinal like time interval. I agree with what Gary just said. We did 2008, 2010, and then 2014 with an eye on half-lives, and those intervals worked well for our project.
This has been excellent, and I think report back is one of my favorite topics to discuss, particularly with clinicians. One thing this committee has grappled with is uncertainty, communicating in the face of great uncertainty. And I think you've all discussed this or added to it, but I would like to hear your direct thoughts on communicating the uncertainty of, you know, the source of exposure, uncertainty of what the level particularly means, the uncertainty of maybe not capturing all of the chemicals in the blood, lots of avenues of uncertainty. So I'd like to hear your comments on communication in the face of uncertainty.
Well, I think those are clearly important messages to incorporate into any reports. You mentioned several different kinds of uncertainty. They can be in context in different places for different parts of the interpretation. I think we find people generally accept that. And when you interview them afterwards, you hear them expressing it back to you. Like, I understand you can't make a one-to-one link, or, you know, I know we don't know, but, you know, so I think we can feel pretty confident that people are getting it because they're saying it back to us.
And I would say, you know, two things, one about exposure and one about health effects. Alan Duckerton was very clear yesterday that there's a tremendous literature, not just from the C8 Health panel, but from so much more research since then, and that too many agencies have downplayed the very strong evidence for many health effects of many different chemicals, not just the ones that are being regulated right now in a few states. So I think we have to pay a lot more attention to that. There's more certainty out there, and I think there often has been in environmental health than a lot of people and agencies are willing to give credit to. The other thing about exposure is, if we talk about the general population, yes, it's hard to say how much came from water, how much came from outdoor clothing, how much came from pizza boxes. But another thing that was mentioned yesterday in Alan Duckerman's talk was a lot of this focus should be on the highly exposed communities. And if you're talking to somebody in Hoosick Falls or in Portsmouth, New Hampshire at the Peace Trade Port, or around the Solvay plant in New Jersey, or somebody who lives near Chemours in North Carolina, these are people in highly exposed places, and we know what the most logical sources of exposure are. They're from foam, they're from industrial process. So we should have a lot more certainty about the exposure and not spend a lot of time focusing on how much uncertainty there is. Because these are things that have been said about so many environmental chemicals and their related health effects for all the time I've ever been in this field for 40 years. And they're often a barrier to getting the work done and to protecting the people who first bring this to our attention.
That's a really important point, that we need to be careful not to overstate the uncertainty.
Excellent. Ned, your hand is up.
Dr. Brown, I was really kind of pleased you went that direction, because my question was going to be a little bit around the issue about your thoughts and Julia's thoughts, and Jessica, and, you know, the rest of the panel around biomonitoring in areas that aren't known to have high exposure levels. I think in some ways it seems, you almost said it, it's easier, it makes more sense if we think about returning results and we think about biomonitoring, we think about systems and advice to clinicians around what to be concerned about in areas where there are communities with known high exposures. And we're also needing to consider what recommendations do we make across communities and across areas where that exposure level is either undetected or unknown. And so I just wonder if you've reflected on the I think you called it the rest of the population, and how we should think about testing, advice to clinicians, educating clinicians, and returning results to patients.
Well, I think in terms of general exposure, we also know a lot of ways to reduce those too. So if people change some of their individual habits, which is not the only thing we want to focus on, because we'd much rather get large retailers to get those products out of the supply chain. We'd rather get states regulating them out of products. And that's happening a lot. So I think if we look at those kinds of data, we'll see declines in overall exposure, assuming that we have enough sampling going on, that we have enough biomonitoring and water sampling going on in communities. And to really see the effects of that in people, we're going to really need to do a lot more biomonitoring, which is more expensive, and there's a lot more resistance to that. So that's one of the things that we can do in terms of general population. And I think, you know, again, more education for clinicians would help us to get more of the blood test data in. And one could imagine even crowdsourcing a lot of this data, you know, much as when Julia Brody talked about the work that we're doing with 2 echo cohorts. That's a great example where you have dozens of children's cohorts compiling all their data together in a mega cohort. We should be doing more of that in terms of PFAS, so that we can find out things that we may not be able to find out just in one state alone.
In terms of general populations, I think I would underscore what Mark said about the need for a public health biomonitoring approach, so that you can find those hotspots. We got surprised, for example, when we tested drinking water in Hyannis and other parts of Cape Cod, and that was the beginning of learning that the fire training area at the airport, but also septic systems and hazardous and waste sites were contributing to drinking water contamination. I think those discoveries are most naturally going to come from a public health point of view, although not necessarily always. For example, in Massachusetts, the Department of Public Health has just wrapped up a study of childhood cancers coming from contaminated drinking water, where the first signal did come from the clinical side. So, and then the environmental contamination was discovered. So you need this interplay between the clinical and the public health knowledge
Yeah, I appreciate that. Dr. Brown, your answer prompted kind of another issue, your previous answer around uncertainty. So I think as we look more into the evidence and talk to more people, the epidemiologic linkage between exposure and health outcomes is strong and stronger for some conditions than others, and so that's the area of uncertainty. But I think, at what level translates to what risk is the area of uncertainty. And I think the C8, I was really fascinated in the recommendations that say, we'll make the recommendation even though we don't have evidence that the screening for conditions related to PFAS exposure is going to make a health difference, which is pretty different than the way preventive medicine kind of looks at screening tests in the Wilson and Jung setting. So I just want to point out there are other areas of uncertainty in addition to the fact that areas of high exposure create a pretty strong epidemiologic link to the conditions that I think we and the community, exposed community members are most concerned about.
Well, I would say sometimes a single study can be enormously powerful. And if we don't wait around forever to duplicate that and replicate it on and on, I think back to the Swedish biomonitoring studies of breast milk and flame retardants and how important that one study was, and how when the Swedish government said right away, okay, we'll get PBDs out of breast milk. And then you saw the rate of PBDs in breast milk just shot down dramatically very quickly. So I think we have to do what we heard yesterday, really apply the precautionary principle. We get some kind of evidence of that sort that's at the exposure level. And we're not looking for the health effect. We're just saying, this is an exposure. It doesn't belong there. It shouldn't be PBDEs in breast milk. Get it out. And I think this is the thing that I've learned a lot over my years from environmental health groups in the community and from environmental justice groups, that exposure is often for them the indicator of action, that we don't want to wait around and count the bodies. There's a lot of biological plausibility. And this is why people in the PFAS world are increasingly saying this is a class-based issue. We don't want to have to wait decades and decades like we did for PFOA and PFAS, not just for the results to come in, but to get all the data that's been suppressed by DuPont and by 3M. So we don't want to have to wait to uncover all that. We want quicker action. And exposure, rather than waiting for long-term health effects, is often the judge of that. And I give a lot of credit to people who have acted on the basis of a few studies. I mean, our PFAS Beach study was based very much on Philippe Grandjean's work in the Faroe Islands cohort. We showed the kids had reduced titers with DTaP because of their higher exposure to PFAS. Well, that's really made a lot of people think about those immune function issues. And we could come up with a lot of other examples too, where a single study is so plausible and so significant that it leads to that level of awareness and action.
Thanks.
Well, this has been a very informative. Did I cut someone off? Did someone have a? Okay. Sorry, I thought I heard someone jump in. This has been a very informative session. I greatly appreciate the expertise that all of you brought to this conversation. All of your comments will be strongly considered and incorporated. If you have any further comments or anything else you'd like to share with the committee, we'd love to have follow-up from you, any new findings, results as you continue to publish and present. And so please just reach out to Liz Boyle for anything additional.
Sorry, this is Gary Ginsberg. I was having trouble unmuting. I just thought one final comment from me, and that is that biomonitoring is another tool that we can use to understand exposures, and we've seen PFOA, PFOS levels drop by almost an order of magnitude since the early 2000s. But the question is, what might be going up and what else? Short chain, for example, PFAS that may be more common now in in the human ecosphere and consumer marketplace. And so I think biomonitoring, status and trends, general public health testing for a wide array of constituents is really a valuable thing to start, getting a baseline and following it over time so we can see as some things drop, what might be going up.
Excellent. Thank you. Thank you so much for that, Carrie. So we have concluded our time. I think I should turn this over to Ned.